A Yorkie walks into your clinic, right?
Right.
And it's intermittently skipping on its back leg.
Oh, yeah. Classic.
You haven't even touched the dog yet, but mathematically, you already know the architecture of its hind leg is actively collapsing. The patella is slipping out of its groove.
Mm-hmm.
So today's deep dive is for the vet student staring down like a massive orthopedics exam, or maybe you're prepping for your very first surgical rotation.
It's a stressful time.
Oh, totally. We are taking your clinical notes and your surgical diagrams and just tearing them apart. We want to completely master the mechanics, the diagnosis, and the surgical fixes of the patellar luxation.
Right, because you really have to know this inside and out.
Exactly. Okay, let's unpack this because this isn't some textbook anomaly you read about once, right? This is the absolute bread and butter of canine orthopedics.
It really is. I mean, it's the single most common stifle joint abnormality in dogs.
Wow, the most common.
Number one. And the numbers, they paint a really clear picture of what you're actually going to see in practice. Over 75% of these are medial luxations, meaning the kneecap slips toward the inside of the leg.
Okay, inside of the leg, got it.
And furthermore, half of all the cases that walk through your clinic doors will be bilateral.
Wait, so both knees failing at the exact same time?
Yes, simultaneously. And while memorizing the grading scales and all those surgical steps is, a requirement for your exams, our real goal today is to look at the underlying biomechanics.
The actual physics of it.
Exactly.
Yeah.
If you understand the physics of why that kneecap is slipping, you can stop just memorizing textbook bullet points. You start thinking like a surgeon assessing a real structural failure.
So before we picture scalpel in hand, we need to visualize that structural failure in the anatomy. We need to know who this patient is and how their leg even got to this point.
Definitely.
Fundamentally, we're talking about the displacement of the patella out of the femoral trochlea, right? That groove at the base of the femur.
Right. And the typical patient profile is highly specific. You're going to see a much higher risk in female dogs, and the condition just heavily dominates the toy and small breeds.
Like the Yorkie from the intro.
Exactly. We're talking about Yorkshire Terriers, Pomeranians, miniature and toy poodles, Chihuahuas, and Boston Terriers.
What about cats? I
Yeah.
feel like we never hear about this in cats.
Well, for your feline medicine exams, you should keep in mind that this is relatively uncommon in cats, but there is one notable hereditary exception,
Oh, which one?
the Devon Rex.
Oh, interesting.
Yeah, but in our canine patients, the clinical signs usually become apparent after 4 months of age, though really severe congenital deformities can show up in practically neonatal pups.
That's just so sad. And the musculoskeletal changes underlying all this are, well, they're wild to picture.
They really are.
Because we aren't looking at a single stretched ligament here. We're looking at a three-dimensional warping of the entire leg. There's tibial rotation on its long axis. The distal femur and proximal tibia are just physically bowing. The femoral trochlea, the groove itself, is abnormally shallow or even completely flat.
Right, and even the massive quadriceps muscle group is displaced.
Yeah, so if we picture the patella as a train, right, and the trochlear groove is the track, if the bone acting as the track is completely bowed or the groove is just too shallow,
Then the train derails.
exactly, that train is going to derail regardless of how strong the engine pulling it is.
The derailed train is a really helpful visual, but we actually have to look even higher up the leg to find the root cause of that warped track.
Higher than the knee.
Yes. The luxating patella is frequently just the final visible symptom of a whole cascade of skeletal deformities. A major contributor is Kochevara.
Which is an abnormally decreased angle of the femoral neck at the hip joint, right?
You got it. And because the hip geometry is altered, the entire femur sits at a strange angle.
Oh, I see.
This abnormal alignment means the vastus medialis muscle ends up constantly pulling the kneecap medially. So you're evaluating a whole limb issue from the hip down to the paw. It's not just an isolated knee problem.
Man, that makes the grading system make so much more sense. We aren't just grading how loose the knee is.
No, not at all.
We're grading the progression of a leg slowly contorting itself completely out of alignment.
Well,
So for a vet student, mastering the grade II through V scale is non-negotiable on the clinic floor. Let's build this from the ground up.
Okay, let's do it.
Grade II seems almost benign.
Yeah.
The patella can be manually pushed out of the trochlea, but the second you let go, it instantly pops back in.
Right. And honestly, grade I patients are often completely asymptomatic. They might not show any signs of pain at all.
So when does it become a real problem?
The real clinical signs start at grade 2. In a grade 2, the patella can be manually displaced or it spontaneously luxates when the dog flexes the joint.
Okay.
But the defining characteristic of a grade 3 is that once the patella is out, it stays out.
Until when?
Until either you manually reduce it or the dog actively extends its stifle to snap it back into place.
Ah, so this is the dog you see running in the park. Right, it's suddenly holding its back leg up and skipping for like 3 steps.
Exactly. Then it extends the leg, puts it down, and just starts running normally again.
Here's where it gets really interesting, though. Why does it present as a skip?
What do you mean?
Well, I always assumed a bone sitting out of a joint would be this constant agonizing pain. Why is it only hurting for those 3 random steps?
That's a great question. The acute pain in patellar luxation rarely comes from the patella simply resting out of place.
Really?
Yeah, the sharp pain actually happens during the transit. It's when the patella forcefully grinds over the trochlear ridge, snapping in and out of the groove.
Oh, ouch. That sounds awful.
It is. It's also caused by physical abrasion over time. The protective cartilage literally wears away from the abnormal friction, creating raw bone-on-bone contact.
Which is agonizing.
Exactly. So the dog skips because the knee is momentarily locked out of position and it hurts to move until they forcefully extend the leg to just snap the patella back onto that worn-down track.
And then the track degrades even further into grade 3. The notes say in a grade 3, the patella remains luxated most of the time.
Most of the time.
You can still physically push it back into the groove when the leg is extended, but the second the dog bends its knee pop, it's right back out.
Yeah, and visually, these dogs have a very distinct crouching posture.
All right, with a medial luxation, the dog looks severely bow-legged, which is termed genuvarum.
Correct. And if it's a rare lateral luxation, they'll look knock-kneed, which is genuvalgum.
By grade 3rd, the structural warping has to be pretty profound, right?
Very profound. A constant abnormal forces have literally shaped the growing bone. And then you reach grade the 4th, where the joint architecture has completely failed.
Grade 3 is the worst-case scenario.
It is. The patella is permanently luxated and absolutely cannot be pushed back into the groove. The bone deformity at this stage is staggering.
How staggering.
Well, you can observe up to 90 degrees of rotation of the proximal tibial plateau. And the groove itself is usually completely non-existent.
Wait, 90 degrees? How does an animal even walk with a tibia rotated 90 degrees? That sounds like a catastrophic failure of physics.
It really is a biomechanical nightmare. Because the hind limbs are so deformed and just mechanically useless, the dog cannot bear weight on them effectively.
So what do?
To compensate, they shift the vast majority of their body mass forward onto their front limbs. They adopt this heavy crouch in the rear and carry themselves with this exhausted, altered gait that's entirely dependent on the forelimbs.
Okay, so a dog is standing on your exam table, severely bow-legged, shifting its weight forward. You need to definitively diagnose this. But more importantly, you need to make sure you aren't missing concurrent injuries that are masking themselves under the luxation.
That's a crucial step.
Right. So what else should be on the differential list? We have tibial tubercle avulsion and patellar tendon rupture, both of which cause the kneecap to ride completely too high.
Which is known as patella alta.
Yes, patella alta. But the notes highlight a massive red flag that a student absolutely cannot afford to miss. Cranial cruciate ligament, or CCL, rupture.
Yeah, a missed CCL rupture will completely derail your surgical success. In roughly 15 to 20% of patellar luxation cases, there is a concurrent CCL rupture.
15 to 20%, that's huge.
It is. The chronic instability of the knee joint, the twisting of the tibia, and those abnormal mechanical loads place massive stress on the cranial cruciate ligament.
Until it just eventually frays and snaps.
Exactly. So during your physical exam, while you are exerting force to grade the luxation, you must simultaneously perform a cranial drawer test or a tibial compression test. You have to evaluate the integrity of that cruciate ligament.
On the topic of diagnostics, the protocol mentions using CT scans or orthogonal x-rays for grade 3rd and 4 luxations to assess the bowing and torsion.
Right.
But let me put on my skeptical vet student hat for a second.
Bye, boy.
Go ahead. If I'm palpating a grade 4 dog and I can literally feel the kneecap sitting an inch away from where it should be, I know it's luxated. The owner knows it's luxated. Why do I need to make the owner pay for an expensive CT scan?
I get that question a lot, but the imaging isn't to prove the luxation exists. You already confirmed that with your hands.
Right. So what is it for?
In severe grades, the imaging is the blueprint required to measure the three-dimensional contortion of the femur and tibia. Remember that 90-degree rotation we just discussed?
It's the biomechanical nightmare.
Exactly.
Yeah.
You cannot plan a complex realignment of the mechanical axis without knowing exactly where the bone curves. The surgeon needs to calculate precise angles for corrective osteotomies.
Okay, that makes sense.
You have to know where to cut the bone, how much wedges of bone to remove, and exactly how to plate it back together so the leg is straight again.
So you're mapping the warp in the track, not just confirming the train is in the dirt.
Exactly. That's
Yeah.
a great way to put it.
And while we're talking about the internal environment of that joint, the pathology notes are intense. The joint capsule becomes redundant and loose on the side opposite the luxation.
While the side the patella slipped toward develops severe fibrosis and tight contracture.
Yeah, and the microscopic breakdown is even worse. The notes mention cartilage fibrillation and a massive loss of glycosaminoglycan content. Can we get an ELI-5 translation of what is actually happening to the tissue there?
Sure. So cartilage is supposed to be incredibly smooth, like wet ice, allowing the joint to glide friction-free.
Okay, wet ice.
Fibrillation means the surface of that cartilage is physically fraying and splitting apart under the abnormal stress. It ends up looking almost like an old, worn-out rope.
Yikes. And the glycosaminoglycans.
Those are molecules inside the cartilage that attract water. They act like the shock-absorbing sponge and motor oil of the joint.
Okay.
When you lose them, the cartilage dries out, it thins, and it loses its ability to absorb impact. The joint is effectively tearing its own protective lining to shreds.
If the joint is actively tearing itself to shreds, a simple diet change isn't going to rebuild a frayed rope. But we have to start somewhere. Let's look at medical management before we just open the knee.
Right. For grade FURs and some grade 2 luxations, it's outpatient care. Weight control is paramount.
Just to reduce the sheer mechanical load on the joint. Right?
Exactly. Weight management is the absolute foundation, followed closely by pharmacologic support.
Like NSAIDs.
Yes. We rely on non-steroidal anti-inflammatory drugs to minimize the pain from that bone-on-bone friction and reduce the inflammation. Clinically, you'll likely prescribe meloxicam.
What's the dosing on that?
You start at a 0.2 milligram per kilogram dose, followed by a 0.1 millikilogram maintenance dose. Or, alternatively, you could use carprofen at 4 millikilogram.
Okay.
You should also consider omega-3 fatty acid supplements to help mediate those inflammatory pathways and chondroprotective agents to try and preserve whatever healthy cartilage is left.
Now, when I hear severe inflammation in a joint, my instinct is to want to throw a strong steroid at it, just to calm it down immediately. Does that work here?
No. Do not use corticosteroids under any circumstances for this condition.
Really? Never.
Never. The long-term systemic or intra-articular use of steroids is associated with significant accelerated damage to articular cartilage.
Oh, wow.
You have a joint that is already undergoing fibrillation and losing its glycosaminoglycans? Introducing a corticosteroid will only speed up the destruction of the exact tissue we're trying to save.
Point taken. No steroids ever.
Good.
But eventually, for most grade 6, and certainly all grade 3 and worthy, medical management hits a wall. The mechanics have failed. You are headed to the OR.
Yes, surgery is inevitable.
The surgical approach here is fascinating because you aren't just tying the kneecap down, you're reconstructing the entire mechanical axis of the leg.
That's right.
The notes outline 2 massive procedures that often happen together, the trochlear wedge recession and the tibial tuberosity transposition. Let's start with the first one.
Let's examine the trochlear wedge recession. The objective is to deepen that shallow femoral groove so the patella is securely captured during movement. However, you cannot simply use a surgical burr to grind away the surface bone until a deep trough is formed.
Why not? I mean, that seems like the fastest way to make a groove.
It's fast, but if you grind away the surface, you completely obliterate the hyaline articular cartilage.
Oh, right, the wet ice.
Exactly. The patella would be forced to articulate against raw, bleeding, cancellous bone. The resulting friction and severe osteoarthritis would basically cripple the dog.
That sounds horrible.
It is. Instead, you must deepen the groove while preserving the original cartilage surface.
How do you do that?
You use a surgical saw or blade to cut a V-shaped or diamond-shaped osteochondral wedge, which contains both the bone and the pristine cartilage on top, entirely out of the trochlea.
Ah, I see. It's like needing to dig a deeper trench for a drainage pipe in a perfectly manicured lawn, right?
Yeah, that's a good way to look at it.
If you just take a shovel and gouge a trench, you destroy the lawn. So instead, you carefully cut out a geometric patch of the sod of the grass and set it aside.
A highly accurate analogy. Once that wedge of sod is removed, you go back into the exposed defect, and remove a secondary layer of the deeper bone. You are digging the dirt out from under the trench.
And then you take that pristine wedge of grass, maybe trim the dirt off the bottom of it with rongeurs, and just drop it right back into the newly deepened trench.
Precisely.
The surface is completely intact, but it sits deeper in the ground.
Exactly. By replacing the wedge, the patella continues to glide against smooth, native, articular cartilage. And what's fascinating here is that both surgeries directly address the malalignment.
Right.
The biomechanical benchmark for a successful recession is that the newly deepened groove must be deep enough to house at least 50% of the height of the patella.
That is just brilliant surgical engineering.
But
Deepening the groove only fixes the top half of the problem. We still have a twisted tibia pulling the patella sideways from below.
which brings us to the tibial tuberosity transposition, or TTT.
This procedure sounds so aggressive. We are literally breaking off the piece of bone that the patellar tendon attaches to and moving it.
It's a major realignment.
You start with an incision through the fascia lata, reflecting the cranialis tibialis muscle to expose the tibial tuberosity.
And this requires immense precision. You pass an osteotome or a sagittal saw behind the patellar tendon. You make a cut, an osteotomy, starting behind the patella and cutting downward. But students must remember, this is a partial osteotomy.
Partial.
Yes. You must leave the distal periosteal attachment completely intact at the bottom.
Wait, you don't cut the bone completely off. Why leave it attached to the bottom?
For two critical reasons. First, that periosteal attachment preserves a vital blood supply to the bone fragment, ensuring it actually heals.
Okay, that makes sense. And the second?
Second, it acts as a hinge and an anchor. You're creating a bone flap, not a loose bone chip. Once the cut is made, you prepare the new attachment site laterally by rasping away the cortical bone to expose a bleeding surface.
To help it fuse later.
Right. Then you pry the tuberosity over into its new aligned position.
But you've levered the bone flap over, and the massive quadriceps muscle is still attached to it, pulling upward with enormous force.
It is.
How do you stop the muscle from just ripping the bone flap right off the leg?
You secure it initially by driving one or two small K-wires through the tuberosity. You direct them caudally and slightly proximally into the main body of the tibia.
Just pinning it in place.
Yes, but here's a crucial technical warning. You must engage the back wall of the tibia, the caudal cortex, for stability. But you cannot let the sharp pin exit the bone into the soft tissue behind the knee.
What happens if it does?
A protruding pin will cause severe chronic lameness as it constantly rubs against the popliteal region.
The notes mention that for anything larger than a tiny toy breed, those pins aren't strong enough on their own. The quad muscle is just too powerful. You have to reinforce it with a figure-8 tension band wire.
That's right.
How does a piece of wire stop that pulling force?
It's an elegant application of physics. You drill a transverse hole through the tibia below the osteotomy. You pass orthopedic wire through that hole, loop it upward in a figure-8 pattern over the exposed ends of your K-wires, and tighten it down.
Okay, I'm picturing it.
The figure-8 configuration alters the mechanics of the quadriceps upward pull. Instead of the muscle pulling the bone fragment away from the tibia, the tension band captures that kinetic energy and converts it into a compressive force.
Wait.
Yes. Every time the muscle pulls, the wire forces the bone fragment to jam tighter and harder against the tibia, which dramatically accelerates bone healing.
Converting a destructive pulling force into a constructive compressive force. That is incredible.
It's a lifesaver.
And while you're in there, the notes specify you also have to address the soft tissue. Remember that fibrosis and stretching we talked about earlier?
You can't ignore the soft tissue.
Right. You have to perform a medial capsulotomy, literally cutting the tight contracted joint capsule to release the tension, and then imbricate, or surgically tighten, the stretched out redundant tissue on the opposite side.
Because if you perform flawless bone geometry but ignore the soft tissue, the contracted capsule will simply pull your transposed bone right back out of alignment.
So it requires a total skeletal and soft tissue reset.
Absolutely.
Okay, so the pins are placed, the tension band is tight, the soft tissue is balanced, and the dog is waking up. The surgery is over. But the vet student's job is just starting.
The post-op period is critical.
The nursing care and the conversation with the owner will dictate whether this $3,000 surgery actually holds together. Immediately post-op, we're talking cryotherapy, right? Icing the stifle for 5 to 10 minutes every 8 hours for the first 3 to 5 days to fight the massive swelling.
Yes, and you also want to initiate gentle, passive range of motion exercises as soon as the patient can tolerate it.
But the owner must understand that activity restriction is absolute.
non-negotiable. If the dog had a groove deepening and soft tissue reconstruction alone, they're restricted to strict leash walks for 4 weeks with 0 jumping.
And if they had the TTT?
If you perform the tibial tuberosity transposition, the dog requires strict cage rest. They cannot be allowed free roam until follow-up radiographs confirm that the transposed bone has completely healed to the tibia.
Because a sudden jump off the couch could easily rip the pins out and just shatter the repair.
Exactly. It happens, and it's devastating.
Which leads to the hardest part of the job, client education. The harsh truths. You have to sit the owner down and warn them about the relapse rate. Between 8 to 20% of surgically corrected cases will reluxate to some degree.
It's an unfortunate reality.
You also have to warn them about the heightened lifelong risk of a CCL tear in that joint, and the toughest reality to communicate. Degenerative joint disease or arthritis is inevitable.
It will develop in every single dog post-surgery regardless.
Because the joint was unstable, the cartilage was damaged, and we just took a saw to the bone. Arthritis is coming.
It is a sobering conversation, definitely. But you balance it with the clinical prognosis. Despite the inevitable radiographic arthritis, the mechanical reconstruction is highly effective.
What are the success rates?
With surgical treatment, 90% of these dogs will eventually be free from lameness and return to highly functional, active lives. The physics work.
You've diagnosed the skip, mapped the warped bone, deepened the groove without destroying the cartilage, and rewired the leg's tension. You are officially ready to crush this orthopedics rotation.
You absolutely are.
But before we wrap up this deep dive, let's zoom out from the surgical table for a second. We just spent this entire time detailing a staggering, painful, multi-level deformity of the femur and tibia that literally tears the joint's cartilage to shreds. And we know this condition is deeply hereditary, dominating specific toy breeds like Yorkies, Poodles, and Pomeranians. Given all of that, at what point does the veterinary community need to have a much harder, louder conversation with breeders?
That's the real elephant in the room.
Right. If the current aesthetic breed standards are practically guaranteeing a lifetime of structural failure and complex orthopedic surgery for these animals, are we just treating the symptom while totally ignoring the source? It's something to chew on the next time a skipping Yorkie walks through your clinic doors.